Can you hear me now? Can you hear me? Yeah? Okay. Good afternoon, everyone. All right, for those who don't know me, I'm Dr. Balbissi. I'm one of the interventional cardiologists at ETSU Heart. And it's a pleasure to talk to you today about one of the subjects that come across very frequently in our practice, both cardiology and for internal medicine. So I hope it will kind of interest you. I'll try to not go into too much details where it becomes a little bit boring. We'll try to focus on the important things, important trials. There's a lot of literature out there, but we're going to talk about the things that matter. And I'll make a brief review so we know what we have out there, and we'll take it from there. If you have any question at any time, please feel free to ask me. I mean, I'd like a more open discussion or kind of lecture. All right. Any questions? Oh, anyways, overview. So we're going to go over three major things. We're going to talk about antiplatelets and anticoagulants, which agents we have at the current moment. We're going to talk about the literature in regards to the use of these medicines together, and that is currently available. And then we'll talk about how can we deal with such patients, management strategies. All right. So we'll start off with a case presentation. Typical 76-year-old female, known case of diabetes, hypertension, peripheral vascular disease. We see that very frequently. And atrial fibrillation on Coumadin. Presented to hospital with a non-STEMI and underwent coronary angiography followed by a PCI and stenting to the LAD, a major vessel, with a drug-eluting stent. What would be the best regimen? Is it aspirin, Plavix, and Coumadin? Is it aspirin and Coumadin alone? Is it Plavix and Coumadin alone? Is it aspirin and Plavix? Is it aspirin, prasugrel, and Coumadin? And so forth. And now if you put in the newer agents, dabigatran, apixaban, and rivaroxaban, then you have a way long list that you can choose from. But which one is the best? So that's the idea that we're going to try to answer today. But let me tell you from now, we're not going to be able to answer it completely. I mean, we'll try, but we're not going to be able to answer it completely. So we have a lot of questions, a long list. Hopefully you're not going to get this MCQ on your boards. But anyways, it's an important subject. Okay, so what I would like you to know is around 5 to 10% actually of our PCI patients will have atrial fibrillation. And that means that's a huge number, first of all, a huge percent, and that's a common problem. So we have two major categories. We have the categories where we need to give antiplatelet therapy, dual antiplatelet therapy, which is post-PCI, any stents, regardless whether it's post-stable angina or if it's also post-ACS. Now, for ACS itself, forget, even if let's say you have a patient comes in with a non-STEMI, troponins 0.5, you go in, you do a cath, and you find that, well, the lesion is not that bad or it's a small vessel, you only balloon it. So if you did not do stent, you still want to treat that ACS with dual antiplatelet therapy for a year, just for the ACS itself. So both are indications for dual antiplatelet therapy. Now, then we have the indications for oral anticoagulants. So not all indications for oral anticoagulants are equal. They're different, and each one has a different target and a different threshold of doing it, if you want to think of it. So atrial fibrillation, mechanical heart valves, venous thromboembolism, very frequent issues that we encounter in our medical, in our medical career, and then the LV thrombus, which is not as common, but it still can happen. Okay, so basically, this is the scenario that we're always faced with. We're stuck between a rock and a hard place. And those who have round with me probably have heard me say that to the patients themselves. I tell them, listen, with this, we need to discuss it and try to figure out what is the safest way that we can balance so our poor patient is not stuck between bleeding and between ischemic events. Ischemic events, of course, here we're talking both stroke or instant thrombosis or MIs. So both are not good. All right, so let's start with a review of the antiplatelets and oral anticoagulants medications. All right, this is a busy slide, and it's also a complex thing. Actually, 30% of interventional cardiology was about hematology and platelet aggregation. So it's a very important subject for interventional cardiology. I'll try to skim through it. There are those who are actually much better experts on these things than me. But to kind of go over it quickly, the first step in coagulation is platelet aggregate or platelet primary plug formation. And it happens in 3 phases where you have platelet adhesion, platelet activation and then platelet aggregation. And we try to stop it at different phases. The phase that most of our medicines are targeted towards right now is the platelet activation, in a sense. The aggregation is G2B3As work on it more, but we're not going to touch those. Those are IV medicines. We're going to talk about oral antiplatelet medications. Am I going too fast, by the way? All right. So the first couple of things that we can inhibit. First off, you're all familiar with COX-1 inhibitors, like aspirin, where you inhibit the formation of thromboxane, which is a strong activator of the platelet, and it also causes vasoconstriction, so it helps with forming the primary plug. Sorry about that. Can you hear me? It's a cath lab. 5921. Thanks. All right. So as we said, the aspirin, where you inhibit thromboxane formation. And it's a very important step. Then you have the other receptor, which most of our medications work on, which is the P2Y12 receptor. Now, P2Y12 is one of the two receptors for ADP. ADP is one of the strongest activators of your platelets. So the P2Y12 here, once you block it, you prevent the feedback of ADP, and you prevent the further activation of platelets. So what P2Y12 inhibitors do we have? We have the older one, ticlopidine, which is rarely used nowadays. You're all familiar with clopidogrel, or known also as Plavix. Prasugrel is a relatively newer one, Effient. And then you have the ticagrelor, which is Brilinta. Now, prasugrel, clopidogrel, and ticlopidine are irreversibly bound to P2Y12. So once they bind, they won't dissociate. While ticagrelor is actually a reversible inhibitor. All right, now, so these are the platelet inhibitors that we have. Here we have the 2B3As, which are IV and not involved in our talk. It's not a part of our talk. So, moving on. So clopidogrel or Plavix. Each medicine that we're going to talk about today has pluses and has negatives. So clopidogrel, the plus about it, it's been extensively tested, and now it's available generic. The disadvantages is a high probability of resistance. In some literature, the resistance is up almost to 30%. So that's a significant resistance. And there is a possibility of PPI interaction. But nevertheless, it is well tested, and it is easily available. Prasugrel, or Effient. The advantages is there is no evidence suggestive of resistance until now. And, but it is expensive, more expensive at least than the Plavix or clopidogrel. It's contraindicated in stroke. And most of our patients who are actually having coronary artery disease, they have peripheral vascular disease, and they might have ischemic strokes. So this becomes a problem. It is also not preferred beyond the age of 75 because of increased risk of bleeds, and it has slightly higher bleeding rates. Now, ticagrelor is the same. There is no evidence of resistance. It's not contraindicated in stroke. So this is an advantage of ticagrelor over the prasugrel, and also the fact that it's reversibly bound and it has a short half-life. Technically, it should clear out of the circulation faster than clopidogrel or prasugrel. So in case you have a patient who you need to stop it, or he's at higher risk of bleeding, it can go out of the system quicker, technically, but not well proven to do that. As far as it is more expensive, and that's one of the notorious things of it. It does cause dyspnea in general because of the activation of ADP receptors in the lungs. It is something that is a side effect that usually the patients get over it in around a month or so, but it's a possibility. And again, slightly higher bleeding rates. All right, moving on. Now, before I move on to oral anticoagulants, any questions about antiplatelets? Okay, good. So, oral anticoagulants. Now, you all are familiar with the intrinsic pathway and the extrinsic pathway. Now, the most common oral anticoagulant commonly used is Coumadin or warfarin. Now, warfarin inhibits all FACC factors that are vitamin K dependent, which are like 7, 9, and 10 and 2. Okay, so vitamin K antagonist 10, 2, 9, and 7. So, but they, are you familiar with Coumadin, how it affects all this coagulation pathway? The newer agents, like dabigatran, which is known commercially as Pradaxa, is a direct inhibitor of thrombin. The other newer agents, which are apixaban and rivaroxaban, edoxaban, and betrixaban, these two are not as common in the US. These are the two most common in the United States. Actually are factor 10A inhibitors, oral factor 10A inhibitors. So they act a little bit different than Pradaxa. Pradaxa directly on thrombin, this one is on 10A. Okay? These are like fondaparinux, but orally. Okay, so again, we're going to go over them a little bit. Coumadin, the pluses, it's been extensively tested. Coumadin has been around for 50 years minimum. And we know the ins and outs of it. But some patients just hate it. They call it rat poison. Anyways, so generically available and can be reversed. There is an antidote, which is vitamin K, and even if possible, if needed, fish frozen plasma. The disadvantages of Coumadin are monitoring is needed, and that becomes a hassle. Sometimes also monitoring is not easy, or you might not achieve them to be therapeutic. So, and there's extensive both diet and medication interaction with Coumadin, and that can become a hassle. The other thing is levels are frequently difficult to control, which we just talked about. On the other hand, the dabigatran, the plus, there's no need for monitoring. There is less bleeding in general. That is, if you take GI bleeding out. Otherwise, intracranial bleeds, it's less with the dabigatran. There is no reversal agent yet. There is a very recent study coming out talking about a potential reversal agent for dabigatran. But we'll look into that. I'm sorry? Yes. Rivaroxaban. Rivaroxaban, again, no monitoring needed, less bleeding in general, and no reversal agent. And this is something, by the way, that if you're going to start your patient on any medication, I would significantly advise to sit with them and tell them about advantages and disadvantages of this medication, and mention that there is no reversal agents. Not that you don't want them to use it, but they need to be aware of it. Apixaban is the same. Okay. So this is basically a brief review. Again, I'm not going to go into pharmacology. I don't want to bore you, but I just want you to know what medicines we're talking about right now before we go into the literature and before we go into the strategies to treat. All right. Any questions? No. All right. So we have a dilemma here before we go into the literature. There's a lot of studies, both retrospective, prospective, meta-analysis on this subject. And they're plagued by the following problem. First of all, we're not dealing with one disease entity. We're not dealing with one problem. There's more than one issue going on that we're trying to balance between. And some of them are mutually or most mutually exclusive. So first of all, we don't want instant thrombosis. That is an MI, and that's loss of heart muscle. That's the worst case scenario. You don't want instant thrombosis. So you try, and with the newer, with us being more aggressive in stenting and doing more complex interventions, sometimes complete endothelialization is not happening as early as we'd like it to be, and it still lingers around always. So instant thrombosis is a problem, okay? The next thing is bleeding. So, and bleeding can happen in different ways, whether we're talking about GI, intracranial, post-trauma, all of this, it's a bleeding. Then CVA, or strokes and other thromboembolic phenomenon in patients who have either, let's say, atrial fibrillation, so they're at risk for stroke, and or if they have a mechanical valve, and then they might thrombose the valve itself, and it becomes dysfunctional, which is a major disaster also. So you don't want that. And finally, we're dealing with different disease processes. So there is AFib, which has its own intricacies and its complications. And then you have mechanical valves, which also have its own problems. And then you have DVT. Although they all need oral anticoagulants, they're not the same animal. They're different. And the duration of treatment is different. The potential complications are different. So to design a study to evaluate all of this is very difficult in practice. So that's why there are so many different things. That's one part of the thing why it's complex. Then, if you look at study design, there's even more things that come in. We just talked about so many different medicines. And if you try to focus on one, you might come to find that actually the other one was more beneficial. So, or the other way around. So you have so many different medicines, so many alternatives, and so many combinations between aspirin, the oral antiplatelets, and between the anticoagulants. Then we have different regimens that we could just say, whether we're talking about triple therapy, dual antiplatelet, or a combination between a single antiplatelet and oral anticoagulants. Then we have different definitions. So what is bleeding? Is a 1 gram drop in hemoglobin a bleed? Is a GI bleeding only a bleed? Is a transfusion a bleed? So according to how they defined bleeding, the trials or the literature will change, which will make things difficult to focus on and see what is the actual answer. Other questions are also different study designs that have been out there. Okay. So now, there are 3 major regimens that have been evaluated. There's the triple therapy, which is basically aspirin plus one of the oral antiplatelets. Usually, we're talking about clopidogrel, and an oral anticoagulant, which is also usually we're talking about Coumadin. I will go through that. Then there is the dual antiplatelet therapy regimen, which is aspirin plus one of the oral antiplatelets and no oral anticoagulants. The third one is no aspirin and one of the oral anticoagulants plus one of the oral antiplatelets. Those are the 3 major regimens, and they try to study them as much as they can and see which one is the best. So as you can see, the subject is so much complex. There's a lot of things going in with it, and we'll try to find out an answer. One of the biggest trials that tried to answer this question was the WOST trial. Now, don't ask me what WOST stands for. I tried to remember it, I couldn't. Anyways, so they randomized 573 patients. And what they did is they had to have an indication for at least oral anticoagulant and then a requirement to have a PCI. 25 of those PCIs were actually acute coronary syndromes. And then they randomized them to 2 major groups. One was an oral anticoagulant plus clopidogrel. The other one was the triple therapy, an oral anticoagulant plus clopidogrel and aspirin. 65% of the indication for oral anticoagulant was actually atrial fibrillation. But there were other indications like venous thromboembolism and valves. They've used it for a month minimum after bare metal stents and a year minimum after drug-eluting stents for both areas, for the both trials, both arms of the trial. And then they followed them up. Now, the median follow-up time was 358 days, which is not bad. I mean, it's almost a year. And the findings were the primary endpoint of bleeding was significantly higher in the triple therapy. Sorry. So the primary endpoint of bleeding was significantly higher in the triple therapy. Other words, it was safer to use this combination. As far, and you can see here the hazard ratio and the confidence interval. As far as the net MACE, it was also favorable for dual anti-therapy, which is a secondary endpoint. But again, we all know that MACE follows bleeding. The more you have bleeding, you're going to have a worse MACE. MACE, which is major adverse cardiovascular events. Okay, now, this is, well, maybe this gave us the answer then. All our patients who end up needing this, we should put them on these 2. This is not quite correct for 2 major reasons. The first thing, it was a small trial. The sample size is still small to have a good answer. The second thing is this sample size and this trial was not designed to detect instant thrombosis, which is what we're worried about if we take the dual antiplatelet therapy out. So yes, it is safer from a bleeding standpoint, but it didn't, although MACE was also slightly maybe better here, but it was not designed to detect whether instant thrombosis is actually the same between two groups. So until now, we'll talk about it, but this is what you need to know about WOST trial. So bleeding is less, but it's not really strong trial to detect instant thrombosis. Now, Izod triple trial. This is a fairly new trial, and it came out, I think in 2014, if I'm not mistaken. Now, what they did here, this actually came out 2014, 2015. It came out after the guidelines came out. Basically what they did is these patients were already having an indication for oral anticoagulant, and they were undergoing drug-eluting stents, so no bare metal. All were drug-eluting stents, and they were randomized for 6 weeks versus 6 months. So now in this Izod triple trial, they were looking mainly to see duration of therapy. So the first WOST trial, they were seeing whether which combination of therapy, triple versus single antiplatelet and oral anticoagulant. This one, no. What they want you to see is how long should the treatment be. Triple with aspirin for the triple therapy. Aspirin, clopidogrel, and oral anticoagulant, which was mainly Coumadin in both trials. Now, and after that, they would give aspirin and oral anticoagulant. So after this period, so the first group, they would give 6 weeks of aspirin, clopidogrel, and oral anticoagulant for 6 weeks, then just aspirin and oral anticoagulant. And then the other arm was 6 months of the triple therapy, and then followed up by aspirin and oral anticoagulant. So what they found is, interestingly, is there wasn't significant difference between the two groups. In the primary endpoint, which is a composite of death, MI, thrombosis, stroke, and TIMI major bleed, which suggests that a 6-week period, a shorter triple period, is not safer than a longer 6-month period. But again, take it with a grain of salt. Why? All right, if you look at the difference here, TIMI major bleeding, and again, this is why I talked about definitions. TIMI major bleed, yes, it wasn't that much significant. It did not reach statistical significance. But if you go by BARC classification of definition or definition of bleeding, there was a difference. It was safer in the 6 weeks, but it wasn't designed to be assessed by BARC definition. It was designed to look at the TIMI major bleed. So just the definition of bleeding made a difference. Second thing is, the second thing in here is the stent thrombosis was relatively the same. And it was underpowered for assessing smaller bleed differences. All right, next. Now, the third trial that I want to cover today is the active W trial, which pretty much a big part of you are actually familiar with it. In active W trial here, they looked at mainly clopidogrel and aspirin, dual antiplatelet therapy, instead of oral anticoagulants for indications or for AFib. See whether just a dual antiplatelet therapy, if that works, then that's good. You have a patient with a stent, just put them on those two and it should be fine. Unfortunately, it didn't work. And what you need to know, this is an important point here as well. Efficacy outcome, standpoint of stroke, actually this regimen, the dual antiplatelet therapy, was inferior or not as good as the oral anticoagulant. It did achieve some protection against stroke, but not as good as Coumadin. So, and at the same time, the bleeding between in both the groups was similar. So you're losing stroke protection, and at the same time, you have the same bleeding risk. that pretty much took the dual antiplatelet therapy regimen out as a use for AFib anticoagulation. Okay? Now, so what is the current guidelines for this scenario? We've talked about it a lot, but what is the current guidelines? Now, the current guidelines are very, very vague. Actually, they're well written in a way that pretty much does not answer you. All right, I'm going to read it verbatim because I actually admire them for the way they put it. So if you read it here, the duration of triple antithrombotic therapy with a vitamin K antagonist, aspirin, and P2Y12 receptor inhibitor should be minimized to the extent possible to limit the risk of bleeding. I mean, what do you get out of this? I mean, I know they're smart guys, and they put it twice in the non-ST and the STEMI, but this is pretty much very vague. I mean, it doesn't really actually tell you what it is or what to do. So we're going to try to answer that question. But in fairness to them, this was done before Izod triple came out. So they did not have that much recommendations regarding whether to use the shorter duration or the longer duration of the triple therapy. Okay. Now, to the future, there is an ongoing trial which is called Pioneer FSCAI trial. And what they're looking at is, by the way, if you've seen, most of our trials are based on Coumadin and Plavix. There's not much on prasugrel or Brilinta yet, or ticagrelor yet. And now they're actually evaluating rivaroxaban. So what they're doing is they're using rivaroxaban plus one of the oral antiplatelets as one arm. Then they're using the triple therapy with rivaroxaban, aspirin, and clopidogrel, or one of the other antiplatelets, versus the third arm, which is the usual triple therapy with Coumadin. So 3 arms: rivaroxaban and an oral antiplatelet. The second arm, triple with rivaroxaban. The third arm, triple with Coumadin. And we'll see what the results of this trial will show. It's not out yet. Okay. Any questions? Okay, either we're really good or we're way off. Okay, now management strategies. I'm going to say some bullets that we need to keep in mind when we're looking at our patients, and then we'll try to come up with a summarized approach if possible. Again, this is a suggested way. There is no strong literature behind it, and it's just a way, a general, not guidelines, general way of thinking, let's put it. Okay, so now dosing. In general, if you are going to use a combination of medicines, try to use the lowest dose possible. So if you're using aspirin, don't do the 325. You're not going to gain from it. You're going to gain more bleeding, not much of prevention of ISTs or strokes. So use less than 100. 81 is what we have available. If you are doing warfarin, rather than titrating it to the highest level, try to titrate this at a lower range. So if we're talking about AFib or venous thromboembolism, we're talking about 2 to 2.5, the INR. And try to do more frequent INR checks. Okay, there's always the discussion about stent type, whether we're talking about DES and bare metal stent. And this is also important. Our usual gut reaction is, okay, this guy is going to need triple therapy, put a bare metal. Let's think about it twice. First of all, bare metal has a much higher TVR, target vascular revascularization, much higher risk of instant restenosis. And now with the newer design or third generation drug-eluting stents, the instant thrombosis is not significantly higher than bare metals. So maybe bare metal is not, they've done actually a couple of trials. One of them is the Zeus trial, and there's the AFib coronary artery stent registry that they looked at, and it suggested that they have comparable MACE and bleeding events between these two things. Now with the Zeus trial, of course, they use a tacrolimus stent, which is a third generation stent. So we'll talk about how to use it, but don't exclude drug-eluting stent just because he's AFib and he needs triple antiplatelet therapy. You need to balance it. And we'll talk about how to approach it in a minute. So not necessarily drug-eluting stent off the table. All right, duration. We talked about a little bit about duration while we're going over the Izod triple trial, but basically it all comes to this. The more you wait, the more endothelialization you have, the less your ischemic events happen, and the less instant thrombosis. And the longer you wait, the more chances you're going to start having bleeding events. So again, we're stuck between a rock and a hard place. So we're going to try to find a middle ground. And with Izod triple therapy trial, it showed that maybe the 6 month is not so much of a bad idea. It looks the same as the 6 weeks. However, I remembered now, there was a point I wanted to talk about Izod triple that I forgot. In Izod triple trial, they did a post hoc analysis for the duration after the different durations. So right now, in the one arm, you have the 6-week triple, and then it goes to the oral anticoagulants and aspirin. The other arm was up to 6 months. So there is a time difference between the 6 weeks to 6 months. When they looked at the bleeding events in that time period, as expected, there was more bleeding in the triple therapy in contrast to the other one, which was just the oral, and it was more with the prolonged therapy, yes. So the post hoc, but it's not designed to assess that. So as I said, the Izod triple trial has some drawbacks in general. Okay. Beyond triple therapy, what should we do after we stop, like after a year? Usually, the best approach would be an aspirin and oral anticoagulants. Okay. Now, what about the other oral antiplatelets that we talked about? Prasugrel, ticagrelor. Ticlopidine, we don't use it as much because it has a high risk of causing leukopenia, which is a serious side effect, so really it's rarely used. And it also causes other problems. So right now, there is no strong data to suggest the use of them regularly in triple therapy. So we only use Prasugrel or Brilinta as part of the triple therapy if you have an allergy to clopidogrel or resistance to clopidogrel. So your first choice is going to be clopidogrel. And even if you end up cornered in using one of them, you have to use them with extreme caution and be careful about that. Okay, how about the newer oral anticoagulant agents? Can we use them or not? Again, we don't have any strong data, so still not preferred. We'll see whether that Pioneer AF PCI trial is going to give us any information. But in this case here, with oral antiplatelets, as we went over it before, there is a slightly increased risk of bleeding with the Prasugrel and Brilinta in contrast to clopidogrel. But with these, they actually have less bleeding. So if you have a patient who's difficult to control, he doesn't want to follow up his INR, you're thinking he might be at higher risk of bleeding other than not related to the triple therapy, you could consider actually using these agents, but maybe at a lower dosing. But again, this has not been proven by literature. This is just recommendations and consensus from the societies, or people who have been in the field for a while. Not me, by the way. All right, dabigatran, usual dose is around 150. There is a lower dose, but it's not available in US. Rivaroxaban, rather than the 20, you could use 15. And apixaban, rather than 5, you can use a 2.5. But you cannot use any of these agents for valvular disease. So if you're talking about mechanical valve, it's out of the question. Or a fib with a bronchoprosthetic, also out of the question. All right. Now, another thing which is very important is all these patients need to be on PPI, all of them. You have to protect them. It's actually a class 1 indication by ACC. Okay, so now we've spoken a lot about different things. So what are we going to do? How are we going to treat our patient? A big part is we went over the literature and we talked about what we have. There's a lot of ambiguity. There's a lot of positive things, negative things, but we know now what it is. Comorbidities play a big role, and we're going to try to see how we can assess these comorbidities. But frequently, we forget a very, very important piece of all of this discussion, which is the patient himself. You've got to discuss these things with the patient. I would strongly encourage you not to make the decision by yourself. I know sometimes it's challenging. Sometimes some of the patients tell you, I don't really want to know, do whatever you want. At least you've done your part. But I think it's very important that you sit with them, try to explain it in their words as much as you can, what are the positives and the negatives of each approach and why you're doing it. And let him be part of the decision. This is very helpful because it increases the likelihood that the patient would be compliant. It increases the likelihood of less problems and less complications or less disasters down the road. And at the same time, it is just better medical care. All right. Now, we talked about comorbidities. So how are we going to assess comorbidities? One of the major things is, as I said, 65% or a big part of the patients we are needing the triple antitherapy on is atrial fibrillation. So we have two solutions. The first one is send them to Dr. Ramu and let him ablate it and get rid of it. The second one is actually we have to assess whether we really do need it or not. So we all are familiar with the CHADS FACC score. This is the one we use right now. The CHADS 2 score is kind of outdated. This is the more appropriate one to be used. If you have a patient who has a 1 or 0, he's at very, very low risk. So committing him to triple therapy, triple therapy might be an overkill. You're asking for more complications, minimal protection. So probably you're just good with treating him with dual antiplatelet therapy. So otherwise, if we're talking about above 2 and above, the risk of stroke becomes considerable, and you should consider some sort of a regimen for him, which we'll try to devise in a minute. So this is one way to assess comorbidities. The other way is also looking at the bleeding risk, has bled. And you're all familiar with it. Anything 3 and above is considered high risk for bleeding. And at that point, you also need to adjust your regimen for it. Okay, so suggested approach. Again, this has not been proven by strong data, but it's based on the data that we just talked about as much as possible. We have 3 components. We have type of stent, we have a bleeding risk, and ischemic risk, which is very difficult to assess, and then the recommended triple therapy duration. All right, if we're talking about a drug-eluting stent, and the bleeding risk is low, which means it has bled less than 3, and the ischemic risk, we're talking ischemic risk here, not strokes, we're talking more acute coronary syndromes, MI, instant thrombosis, is average, which is, here again, there is no good way to assess it objectively. It's more individualization of treatment according to the patient. Then you could consider a 3 to 12-month period of triple antiplatelet, triple therapy. Again, 3 to 12 is a wide spectrum, but you could use shorter durations. And you could, and again, the idea is after you're done with the triple, so you do 3 months, let's say, of triple, you don't switch them to only aspirin, you switch them on a combination of aspirin and oral anticoagulant. So after this triple, you go here. Now, if you have a drug-eluting stent and still the bleeding risk is low, but you have a high ischemic risk, usually an acute coronary syndrome, then a 6 months minimum is what you need. And then you follow them by these 2. Drug-eluting with a high risk of bleeding, now you cannot afford a prolonged durations of triple therapy. So you could do as short as 1 to 6 months. Again, this is mainly dependent on the Izod triple trial, and followed by these 2. Then drug-eluting stents and very high risk of bleeding, then probably you shouldn't do triple therapy. And you should depend on WOST trial and just do these 2. Finally, if you are not stuck with the drug-eluting stent already, and you have a patient who has high risk of bleeding, which is, has bled above 3, probably still we are safer to go with a bare metal stent, and you only do 1 month of triple therapy, and then you're good. Okay? Now, summary. First thing, you have a patient who ends up needing a dual antiplatelet therapy, and he needs oral anticoagulants for whatever reasons we talked about in the beginning. What do we need to do? We look at the type of stent, we look at the ischemic risk and bleeding risk, and then we try to come up with how much of the triple therapy he needs. We're going to use the lowest dose of aspirin, the lowest clopidogrel unless there's an allergy or resistance, Coumadin with an INR 2.5 unless it's difficult to control, then we go for the newer agents. After this period, we will switch him to aspirin and oral anticoagulants. DES is preferred because of lower TVRs down the road, unless you have a high risk of bleeding, or the vessel that you're working on is a huge vessel. You're going to put a big bare metal stent, and there's no reason to put a drug-eluting stent. Then low ISR risk, you can do a bare metal and just be done with it. All right, so this is the presentation. Any questions? Go ahead, Nadia. I know. Mm-hmm.
So I don't know if this Izod triple trial, how quickly that was measured and that compliance was measured. If we just limit the triple therapy to just 6 weeks and then switch them to Plavix and anticoagulation, don't be putting them at high risk of infection.
Okay, so what you want to...
Like in real world, I mean, in Izod, of course, I don't know how quickly it was controlled, but in real world, there will be some therapeutic.
I got you. That is correct. That is correct. I can't tell you it's not a possibility. You know, Coumadin control is one of the biggest things that has plagued Coumadin in general. And actually, even in trial situation, achieving a therapeutic INR in the best trials have been in the realm of around 30 to 50%. That is in the best trials to achieve a therapeutic INR throughout. So it's very difficult. So there is a problem, and it's an inherent problem of Coumadin. But whether you know, you're putting them at risk, they followed them up for 9 months. So there's 3 months after stopping it, and they did not have increase in bleeding, in events, in ISTs. So I'm hoping that aspirin and Coumadin looks like it's doing the job. But can I answer you from the top of my head without a trial that is specifically designed to assess that? I can't. Dr. Levine. That is exactly, that's absolutely correct. There is a big, big problem with them. And actually not only that, pretty much all the trials that have been involved in assessment of these have been plagued by lower number. Another also category of trials that have been plagued by lower numbers is the trials that they were used to assess the length of dual antiplatelet therapy for different stents. Now, this dual antiplatelet therapy, the 1-year dual antiplatelet therapy recommendation, was mainly designed for first, second generation stents, not as much as second, third generation. So we have much better stents now that we have not assessed. But all the trials that have been designed, like Excellent Trial and Pegasus, they have been all small trials to make a strong, solid decision. We do need a huge, large number trial to assess and answer these questions. Unfortunately, we don't have it yet. Pooja? That is a good question. All right, so that's another lecture, by the way. The interaction between Plavix and PPI. Most of the interaction between Plavix and PPI is more of an in vitro interaction that has not been translated to a clinical difference. So if you check the PFA of a patient with Plavix and PPI, and a PFA on Plavix only, you'll see the patient who have PPI, the Plavix might not be working as good. But if you look at whether they're having more clinical events, it hasn't been translated to that. So that's why it didn't make it as a change in the guidelines. Yeah. Yes, it has. And it didn't work. That is correct. By the way, and now there are trials that are trying to assess the newer agents, rivaroxaban and apixaban, for the same thing. Rather than oral antiplatelets, use them to prevent it. But they're not, yes, there are, but that's not me who designed them. They're out there. They're working on it. Yes?
So if a patient is on, let's say, triple therapy, like aspirin, Coumadin, and they develop the bleeding, like in Victoria, it's not like
Severe bleeding.
I would say moderate bleed, and you want to stop at least not all of them, some of the medicines, but if bleeding is relatively tolerable, which one do you stop?
Okay. And what is, you see, there is no one answer fits all. Again, I would go individualization of treatment. So if I would have to look at the patient. If the patient, I don't want to make the answer complex, but if the patients, let's say, I look into two major things, which one he really actually needs. If there's, how much does he need the oral anticoagulant? If his risk for stroke is not too high, maybe I can do without the oral anticoagulant. But if his risk for stroke is high, so I need that. So I look now into the dual antiplatelets. What I would do is I would lose the aspirin and probably keep the Plavix and the oral anticoagulant based on WOST trial. Yes? Okay. The question is loaded. The question is loaded with a lot of commercial bias also. So I don't have any disclosures, first of all, by the way, and I don't have any financial things. But all right, so it depends on what you're looking at. The trials at the current time show that science is probably the least to have instant thrombosis. Followed by probably, I mean, I don't know if there's much difference between Resolute and also the Promus. You know, Promus, technically, they said that it's supposed to be exactly like Science, but it's not actually exactly the same. There's differences. But Science has shown the least. There are some minor differences. And other things, also, there are some newer stents that are going to come out. That might be, you know, the ones that without a polymer. They are bioabsorbable polymer, or the bioabsorbable polymer, not the bioabsorbable stents, the bioabsorbable polymers. Those might also have less risk of instant thrombosis. Using imaging to prevent instant thrombosis in a patient you're thinking is going to be a high risk and you might need to do less long is a very smart idea. It's a very smart idea, and I would recommend it because it's a simple thing. Unless, of course, you've reached a point where you're going to increase with your extra imaging contrast load, or you're going to do more and the patient is unstable or whatever. So again, there's no one answer fits everything. But if you do have the time, you haven't used that much contrast, and you have the ability to do imaging to optimize the results so you won't have instant thrombosis, yes, that is a good idea. Did that answer the question?
So patients who have atrial flutter, or even like ATSU, when would you recommend ablation, like if you get into this high risk bleeding?
Okay, well, usually, you know, you need to have them anticoagulated before you do the ablation, and usually you need them 3 to 4 weeks. Is that correct, Peter? Yeah. Zap it. Go ahead, Pooja. There's no trials. No, there's no trials to no. The answer to that question is what Dr. Levine said. They've tried Coumadin before. It's not a new idea. They tried Coumadin, it didn't work. Antiplatelets is the better thing for stents. So a higher INR is not going to do it. No. Long time. That was actually the boom. That was the savior of interventional cardiology, clopidogrel. Yes, go ahead. I have many patients. Uh-huh.
Both come with a huge MI.
Uh-huh.
Intra-procedure, would that skew your choice of use of anticoagulant?
Okay. All right. Dual antiplatelet therapy. So I have a patient who's already on dual antiplatelet coming in for MI. MI, not acute coronary syndrome. Yeah. Okay. So yes, I am going to do the full thing. I'm going to do anticoagulation with most probably heparin. Do I need 2B3As? Unless I find a high clot burden, probably I'm not going to do a 2B3A. So, but probably I will do strong dose of heparin, 250 to 300 ACT. So that is if I'm already on dual antiplatelet therapy. If I'm on triple therapy, it becomes tricky because now you don't know where you are. And the INR, there have been patients who have INR of therapeutic INR from 2 to 3 and still will develop thrombosis in the coronaries. So I cannot rely on Coumadin to do my intervention on. So probably I would do heparin again because I can reverse, I can control it. I won't use any other agent. Do I need 2B3As? They're already on triple therapy. No, definitely I would not use. I would try to shy away from using 2B3As as much as I can. And access side, if I could do that one radially, it would be good. Okay. Any other questions? All right, guys. Thank you so much. Mm-hmm.